Hi friends, Peter Uselak, the Embryo MD here. Today I want to talk to you about the proper approach to fertility medicine in terms of doing diagnostics before therapeutics. So there's a lot of push sometimes from external forces to kind of not spend the proper amount of time looking into what could be the problem when you're having trouble conceiving and moving straight to a therapeutic. But the proper way to approach a problem like not getting pregnant as fast as we want to is start off with some proper diagnostics before we move to therapeutics. So we have to go in that order, because if we go straight to therapeutics, we may be coming back to figuring out later a missed problem. So what I want to do in today's video is just kind of break down the basics of diagnostics. And I find the easiest way to remember this, hopefully we can achieve this just with this short video so you walk away understanding these are the basics of fertility diagnostics. One, we have to know about the eggs. And typically we want to know if ovulation is occurring, and then some sense of what is the ovarian reserve, which is a loose way of describing the quantity and the quality of the egg supply that is remaining at the time of the assessment. Two, we want to know about anatomical features or characteristics of what's going on. So what that means is we want to know about the uterus, and we want to know about the fallopian tubes. And I'd also put into this second area, we want to know endometriosis status. So that's what's sometimes referred to as a peritoneal factor, and that kind of affects the entire pelvic region and also throughout the body too. But we can just do some kind of assessment on that. Three, we want to know about sperm status, and sperm status is most easily assessed through a simple semen analysis. Now, that's the first tier. It doesn't tell us everything, but it's a good way to start. If we miss something in those, that would be really kind of not defensible, because those things are very basic, right? And they're very easy to do. They don't cost that much to do. And so I'll take you through kind of some of the diagnostics to assess those three areas. And in the simplest form, again, what I like to refer to as kind of a first tier look at what's going on. Area number one, eggs. A simple history will usually do really well at telling us whether we think ovulation is occurring. There's lots of things that we can do at home to add to that history, like monitoring with either urine-based products or sometimes temperature-based products or things like that to evaluate menstruation. Something as simple as a diary, taking counts of a menstruation, which is roughly 4 weeks, plus minus a few days. That will tell us, again, in a big picture point of view, if that's really a culprit that wouldn't be causing you to get pregnant over a prolonged amount of time. The second part of eggs would be, again, that ovarian reserve assessment. The easiest way to do that is to look at an ultrasound and do something called an antral follicle count, or do a simple blood test, which would be a hormone called either AMH or you can use basal FSH. So AMH is anti-Mullerian hormone, FSH is follicle stimulating hormone. And looking at those can give us some insight into that concept of ovarian reserve. Okay, let's leave area number one, move into area number two, the anatomical factors. The uterus is assessed through a two-dimensional ultrasound, which any fertility doctor would typically perform on your first visit, to look inside, which is we term the cavity of the uterus, where an embryo would latch onto and grow in. We can use something called a saline sonogram or saline infusion sonogram, SIS. To look at the fallopian tubes and whether they're open, we would use something called typically a hysterosalpingogram or an X-ray dye study. And that tells us if they're open, doesn't tell us fully about functionality of them. And then the endometriosis test, we could assess by a non-surgical method, but we'd probably start out with more of a history on that and see if there's some historical features that were making us think about that. And then moving on to the third area, the sperm, we would perform a semen analysis. And that tells us things like the volume, the count, the movements, the shapes, the morphology of the sperm, just characterizing what a typical ejaculate would look like. And that's pretty much, again, the end of tier one, the very basics of fertility diagnostics. And so those are our three areas. And really, you have to look at all of those before you move on to therapeutics. So things that we do as physicians to help boost the chance of getting pregnant, you really got to make sure you do all those diagnostics first. Let me give you an example of a problem that could occur where you move on to therapeutics before diagnostics. One example of that is, say you had a history of being pregnant in the past, but the pregnancy was actually assessed and first recognized through a over-the-counter urine test that showed a positive value. The history might be that menstruation was late, a urine pregnancy test was performed as positive, menstruation remained late, the urine test remained positive, so it would infer an ongoing pregnancy. But then eventually that went away and a menstruation ensued. Most individuals are going to interpret that as a pregnancy, and a pregnancy in the uterus that then failed and went away. However, it is possible that that pregnancy never made it to the uterus. It actually was an ectopic pregnancy. And so going back to our original diagnostic test that we want to always accomplish before we move on to therapeutics, something like an X-ray dye study and a hysterosalpingogram may have been not placed in high priority, or may have just been kind of bypassed because of the history of the apparent intrauterine pregnancy that occurred. But again, we didn't know that that happened for sure. We don't know that it wasn't ectopic. It's not a high likelihood of that, but we don't know for sure. So if you skip the tube test at that point, you may be missing a problem. So the point of that story would be, you really have to complete all these initial diagnostics. You don't know what's going on there. You really have to complete them all before you move on to entertaining any kind of therapeutics. One last point. When you complete those initial diagnostics, it doesn't mean that there's not something deeper. There are additional things that we can look for, but as we go deeper, we also get into very, very much more atypical things. So they're not very common. That kind of, again, first tier, I term it, those are very relatively common things. My tubes are blocked. I don't ovulate. I have diminished ovarian reserve. I have low sperm count. Those are very common reasons to have trouble getting pregnant. So when you complete all that, it doesn't mean that we can't unmask something else later in a further diagnostic, but it's just not very common. So we all agree upon, on our side, on the practitioner side, we all agree upon, let's just do these first tests, and then at that point, you could move on to some therapeutics, knowing that sometimes in therapeutics, you discover further things. You have to recognize that too. I'll give you an example. Let's talk about egg quality a little bit. No test that we've talked about today, or there is no test that actually assess egg quality or how good of an embryo might I make for my eggs. The only way you might get a clue on that is if you go into the laboratory and you see your eggs turning into embryos and how those embryos perform, and that would be a clue that there might be an egg factor all along. But you would never know that until you moved into therapeutics. So we'll save that for another video to talk about that more, but that's just an idea of understanding that after you leave first tier, there might be something else we haven't discovered yet. So it's necessary, but it's also not 100% complete. Okay, I hope that video helps set things straight in terms of how the proper way and the proper order to do things and to approach things in fertility. And if you like this video, please do give me a thumbs up, and please don't forget to subscribe to this channel, the Embryo MD.